The next presentation is from the chairman, Dr. Kun. Please go ahead. Thank you.
First of all, thank you so much for all of you participate here after nearly the lunch time. So I hope that this presentation will help you sometime when we have Venus stroke. And as you know, venous occlusion is not so common, but after COVID-19, it's become very common, especially in our region. I don't know in other countries like Japan and Malaysia, Indonesia, but yeah, it's the real thing. We has a lot of venous occlusion after COVID-19. And some of the report they saw that can be related to the infection of COVID-19. That's why we have a significant number in my center. And just go through and the main point of this presentation to show how can we treat the venous occlusion in very severe condition. And before to talk about the venous occlusion, we need to learn about the anatomy, because sometimes the patient has no transverse sinus on the left side, and sometimes has a very small hypoplasia, so you cannot make the decision to dilate or just give same variation of anatomy. And this is some of the venous water, but we must remember that it's a variation, especially on venous. It's more than the artery and very difficult to realize. And I don't know, but most of the doctor, we more focusing on artery, not the venous. So before we perform the venous intervention, you should realize and learn about the variation of the patient in every cases. And the cerebral venous thrombosis is has significant and variation of the symptom. The minor symptom, just a headache, and severe symptom, deep coma, and especially bleeding. It's a more dangerous complication and the symptom of the patient. And it's truly regarding to the thrombectomy for the venous. And this is the strategy of the treatment. Most of the time, we can success with medical management, with the anticoagulation for sure. But in the case you have no choice, and the patient has still bleeding and coma, and up to we need some time for craniotomy, especially the role of the neurosurgeon, like this case. Just remember, want to show you, when we have such a this case, don't wait and don't scare to perform the venous intervention for the patient. And my background is neurosurgeon, so that's why I know very well when the complication of the venous occlusion, we have to do something craniotomy, but it failed most of the time when the patient has a deep coma and severe edema of the brain and severe congestion. So the very first case I want to show you, a female 27 years old. She went to the hospital very big in Ho Chi Minh, and this is a CT scan, and again, and we expect see the venous occlusion, and the patient has medical management only, and she passed away after 1 week of medication. This case very long time ago. And this is the second case, almost the same, where the young lady has vomiting and some infection of the sinus, and taking of contraceptive. You see the first CT scan is look normal. And a few days after the antibiotic, and the patient has suddenly a coma and weakness. And the second CT scan can show you now is a problem. Bleeding and more severe. Now, our doctor, the team realized she has a venous occlusion, and we keep the patient with the anticoagulation, and many things was diagnosed, but the patient has a severe condition finally. And we perform the craniotomy for the patient for sure. And some of the last day, the last hope, the patient has severe venous congestion and the brain edema. And the chief of, actually my teacher, the chief of the neurosurgeon team asked me whether we can do something more for the patient because the patient is a pharmacist. Her relative is a journalist and not neurosurgeon. So I think it is the last chance for the patient. If we didn't do anything, the patient will pass away for sure because no choice, no other choice for the patient because anticoagulation failed, craniotomy failed, and the arterial like this. And this, I think it's the first venous intervention in Vietnam. So, 2011. At that time, I tried to rescue the patient. We combine everything in my hand, aspiration. At that time, no, we had only the spider device and the balloon. And we deploy the spider to the suprasagittal sinus and do the thrombectomy for the patient. And finally, we can rescue her. And up to now, she can work. She can help the children. And in the third case, a female again, 45 years old, also has a venous and bleeding like this. And I think it's very easy to make the diagnostic for the venous occlusion. And it's MI, and you see some of the bleeding and the arterial is normal. And the venous occlusion, again, you see that almost for the horn super sagittal sinus occlusion like this. I think this case, if we still keep the medication, we will fail again. So when a patient has a coma and doubt the symptom, I recommend to try to reopening the vessel rather than to keep to see up to bilateral bleeding, and we cannot do anything more. And this is the way we perform the procedure now. The first we approach with the 14 wire and use a peripheral balloon, small, it's about 4 mm, and the longest one to dilate the sinus. I use a very small, it's about 4, maximum 5 to dilate first, and then we follow with the aspiration catheter. Can be any kind from aspiration. And that's all. It's the mainly technical procedure. And this is the way we perform. And it's after recognize the patient. It's a lot of thrombus, I will see. And follow-up CT scan, the patient improve very, very well. Look at the CT scan, the venous face is wonderful. And I will show you the horn procedure for this case. This is the angel. It's really nice venous occlusion for almost horn super sagittal sinus. And we dilate with a balloon, very small balloon. And it's after. Yeah, still. Not very, very nice, but when you can see the flow, it's time to stop. Don't try to dilate many, many times. We can dissection the venous, and you see that the patient now almost no scar and fully recovery. And another case, bleeding stroke is a very, very difficult. At the first day of 21, when we celebrate for the New Year, the patient came to the hospital like this. See, very senior position in the government. And you know that at that time it's very difficult for me because I'm from another provinces. And I go back to the hospital, and the patient rapidly had diagnosed occlusion of transverse sinus on the right side, and we perform the same procedure, dilation and aspiration and thrombus, and you will see it's really nice. Now I will show you. Again, it's not so difficult to perform the venous thrombectomy. And especially our colleagues just present about the venous stenting. So it's combined. We will discuss more about the change. When we try to recanalize, dilate, and many times we have the venous aspiration fail, we can think about that and waiting for the time of recursion. And you see that the first day, the new year of 21, we have such a case like this. And after procedure, no more bleeding. And I will show you how easy look like now. It's still work for the government. It's a very senior. The two lady inside, so you cannot realize who is the patient. And it's in the case to show you can be related to the COVID-19. Very young boy, it's about 5 years old, COVID-19 infection, and follow a few months. He has a deep coma with the CT scan and MRI like this. We expect this violent occlusion. It's very rare for sure, and very dangerous. If we don't realize and no action, the patient will die very soon because when of Galen injection is the more severity. And you will see what we are going to do now for very young patient, just a boy, and venous occlusion of Van of Galen. And same procedure. Very small balloon dilation and aspiration combined, and we will rescue the patient with the very nice result. And this case we already published to PubMed. You can see, you can find. And now the patient can go back to school normally. No symptom, no communication. You see that. And it's a clot we took out. And this is the patient that normal. You cannot realize anything. And this is the key point. When we had the venous thrombosis, just consider when we have severe condition, especially when the patient have bleed. And after medical management found the patient has deteriorated, we cannot make any decision for more anticoagulation. And Glasgow coma scale less than 12, I recommend to proceed for venous intervention, thrombectomy, especially for the major vein like the suprasagittal sinus, and especially for the vein of Galen. Transverse sinus, sometimes when a patient have bleed, and with the transverse sinus, without bleeding, I don't recommend to do any venous intervention because the vein can tolerate very well and ran to the opposite side. And once again, thank you so much for your attention, and we would like to invite you again for next stroke intervention school in July as SIS Control. It will be the new technologies, new devices, and you can play with the animal lab for intervention. Inject glue, stanting, deploy, calling, play with us, and thank you again.
Thank you.